Funding for Yale Cancer Answers is provided by Smilo Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about cancer outcomes research with Dr. Carrie Gross. Dr. Gross is a professor of medicine and of epidemiology at the Yale School of Medicine. Here's Dr. Weiner.
I like to start just asking people about themselves. And how is it that you came to the career that you presently have? How'd you get interested in the work that you do? Just tell us a little bit about yourself.
Sure. So I'm a general internist, and I think one of the most formative experiences of my career really just arose by happenstance. So when I was a resident, my preceptor in clinic was someone who had completed a fellowship program called the Clinical Scholars Program. That program teaches its research methods, teaches biostatistics, epidemiology, which is the study of populations and what drives health and equity at the population level. The fellowship also teaches about the health system. But the most important thing that this fellowship taught me was that research should be considered as a lever for change. We're not doing research just to try to get something published or to fulfill our requirements for a grant proposal, but research should be considered along the lines of what can we do to make the world a better place. So I just happened to luckily be assigned to this one faculty member who had completed this fellowship, and he recommended that I apply. And then I had a 1-year gap between residency and starting the clinical scholars program, just because the way that the application worked out. And I was asked to be chief resident at Sloan Kettering in New York. Even though I never really had an interest in going into oncology, I was always interested in the field, and I thought it would be a great opportunity. So those two things, both of them seemed almost random. And when I ended up spending a year at Sloan Kettering, and then after that, I spent a couple of years really digging into to research methods to understand how to answer questions that would be applicable at the community or population level.
And you are one of those relatively rare people who is a general internist, but who has really focused all of your research on cancer.
Absolutely. As a general internist, that kind of applies to my personality as well. I'm interested in a number of different things. So one way to help myself focus is to say, all right, you're allowed to do different types of work, but it needs to be within at least a field. So I find cancer to be the most interesting and important. I think there are so many questions that could be answered with regard to prevention, screening, early detection, and of course treatment. That it's kept me busy for quite a while. But yeah, I do try to focus on cancer.
So can you just give us a really brief overview of the kind of research you do? Maybe you could give a couple of examples of studies that you've been involved in.
Yeah, sure. Or I was thinking about this. I might even start with a personal story, then delve into some studies. So I mentioned that I was a fellow in this research program. We were down in Baltimore, and this is 25 years ago, actually. My sister-in-law was diagnosed with a very aggressive brain tumor, a glioblastoma. And long story short, we were able to get her in to be treated actually back at Sloan Kettering. She had her surgery. And then a million questions arose. What type of chemotherapy, where to get radiation. We got her radiation here at Yale for a number of reasons, where she had a wonderful experience. And it was a rough time, most of all for Lisa, of course, but it was challenging for the family to be confronting this condition where, only 1 out of every 20 people is expected to live for 5 years, and far fewer than that are a long-term survivor. But Lisa's still alive today, 25 years later.
Oh my gosh.
So when you unpack that, I was thinking about this. Is it because of this biology? Maybe her tumor is different from others. Is it because she had a great surgeon, which I'm sure she did? Is it because she had really, excellent and thoughtful approach to her radiation and chemo? She was a marathon runner. Is it because she was in, great physical shape? Is it because it's her great outcome because, we're fortunate to have this privilege? We have health insurance. We could get her into Sloan Kettering. We could get her into Yale. So just thinking about this one person who had this miraculous outcome opens up so many questions about what can we do better at the population level to help all patients and all people get access to best quality care. So this gets to this issue of outcomes research, which is looking at what are the end results of, frankly, how are we managing and treating our people? Or a more official or more formal way of saying that is what is the evidence that guides decisions that we make in the clinic and at the population level that can optimize people's outcomes. So the kind of research that we do here when it comes to cancer outcomes focuses on two broad categories. One is comparing different treatments with each other, looking at the adoption of a new treatment, for instance, a new type of chemotherapy, which often has been tested maybe in a clinical trial before it comes to market. Usually they are. And then the question is, does it work in the real population the same way that it worked in the clinical trial? And the second type of research that we do relates to equity. Like I mentioned earlier, like maybe not everyone's able to get into these top tier, high quality cancer centers, and certainly not everybody has insurance and the resources to access care. So really thinking about the treatments people are getting and what are the societal barriers to getting those treatments.
And as part of this outcomes research, do you ever do clinical trials yourself? Not so much drug trials, but other kinds of trials.
Yeah, it's a good question because initially, when outcomes research started, it was thought of as people simply accessing large databases. For instance, a clinical trial would be published that said treatment A is better than treatment B. This is brand new treatment A. In 300 patients, people live, 10% longer. However, in most clinical trials for new drugs that are approved in the population, that they're designed to answer the question, can this drug work in an idealized setting? So often in the clinical trials, the initial clinical trials, they might exclude elderly patients or exclude people with emphysema, heart failure, et cetera. So the initial approach to outcomes research would be to say, hey, why don't we get a huge database with like 10,000 patients who have all variety of age and likelihood of emphysema, heart failure, diabetes, et cetera, and see, does this drug work in the real world? That's still the bulk of outcomes research is looking at real world outcomes. However, there's more of an overlap between these idealized small trials and what outcomes researchers are doing, which is, in some cases, it can involve a large, or what they call a pragmatic trial. I want to see us do a better job of linking the need for pragmatic data. Only 7% of patients with cancer are enrolled in a clinical trial at some point in their treatment journey. I would love for us outcomes researchers, for all cancer researchers, to get this up to 20%, 30%, 40% of patients should be offered the opportunity to enroll in trials at some point. So yeah, outcomes researchers, we need to be doing more trials. It is part of the portfolio, but not enough.
But I think the really important point, among others here, is that we do a clinical trial. We find out that drug A or regimen A is better than regimen B. We really know that in a very controlled setting, and we've deliberately controlled it to make sure that we understand the result. We want to isolate the differences in treatment so that we can really say that if A is better than B, it's not because the populations are different, it's because the drug is actually doing something. But then when we apply that to the world, it can be very, very different. And we see different kinds of side effects. We see different kinds of benefits. Sometimes the benefits are less. Sometimes they're actually more. But that's why we really need to do more than just the trial.
Absolutely. We did a study several years back looking at older patients who have colorectal cancer. And the issue there was who is getting adjuvant chemotherapy, meaning after you have your surgery, there's no more evidence of disease physically visible. Your CAT scan looks clean. But sometimes adjuvant therapy can help to prevent the tumor from coming back. And what we looked at was amongst older patients, what are the factors associated with who's getting adjuvant therapy? And we found people who had heart failure or emphysema or diabetes are much less likely to get adjuvant chemo because they weren't included in the initial studies for the most part. So I think the doctors were saying, well, geez, maybe this will do more harm than good. The tumor is not physically, we can't see any tumor. So there are just certain diseases made it less likely some patients were getting this therapy. But then we looked at the potential benefit of therapy, and we found that even among patients who had emphysema or heart failure or diabetes, it worked. The adjuvant chemotherapy was actually helping to prolong mortality and reduce recurrence. So this is one example in which case having these other conditions was making clinicians pull back on giving a potentially helpful therapy, and it might have caused harm. And of course, things go in the other direction too. Sometimes patients who have severe chronic conditions are getting cancer therapy, and it maybe wasn't a good idea. And we just don't know, based on the initial studies, in which cases the chemo or whatever other cancer therapies are more beneficial or more risky.
Well, and I think all of this underscores the point that research is really critical for understanding how to take better care of people, because it's both the clinical trial research and then it's analyzing what happens after the clinical trial is over and carefully looking at that allows us to then make better decisions as time goes on. And as you were saying before, the real goal of all of this is to alleviate human suffering and, at least from a cancer standpoint, to do a better job with the treatment we give.
Absolutely. And it's an iterative process. A new treatment comes into being, comes into market, and it should be expected that it will work well or work at all in some patients, and maybe it won't work in others. And I think it's critical for us to really dig into the details. And I remember when I first went to medical school, this is, a long time ago, the first day of school, the dean, Saul Farber at NYU, stood up there. He said, all right, you guys, we're going to teach you a lot over the next 4 years. You're going to learn a great deal. But I have to tell you something. Half of what we teach you is going to be wrong. We just don't know which half. And that really stuck with me. When I was studying late at night. I'm like, God, I wish I could just only read half of this stuff. But also it just stuck with me because it has showed this remarkable humility. And I'm afraid that to a degree that's been lost somewhat in our research enterprise, and that we have to look at things over time again and again and again to see what's really working and what's not.
Well, it's a good reminder for all of us that we shouldn't be too sure about what we think we know. So with that, we're going to just take a brief break, and I will be back in just a moment to continue our conversation with Dr. Carrie Gross.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their liver cancer program provides continued care following treatment to manage underlying liver disease and monitor for possible recurrence of cancer. More at smilowcancerhospital.org. The American Cancer Society estimates that nearly 150,000 people in the U.S. will be diagnosed with colorectal cancer this year alone. When detected early, colorectal cancer is easily treated and highly curable, and men and women over the age of 45 should have regular colonoscopies to screen for the disease. Patients with colorectal cancer have more hope than ever before thanks to increased access to advanced therapies and specialized care. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for colorectal cancer. Tumor gene analysis has helped improve management of colorectal cancer by identifying the patients most likely to benefit from chemotherapy and newer targeted agents, resulting in more patient-specific treatment. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Hello again. This is Eric Weiner at Yale Cancer Answers, and my guest tonight is Dr. Carrie Gross, who's the founder and director of the Cancer Outcomes Public Policy and Effectiveness Research Center, called COPPER, and director of the National Clinical Scholars Program at Yale. So, Carrie, let's keep talking about outcomes research and related issues. And maybe I can just ask you first about your thoughts regarding barriers to clinical trial enrollment. Why is it that such a limited number of patients go on clinical trials? And of course, it's not a requirement that any patient participate in a trial, but it's an option that we would like to give many, and we probably don't offer that quite enough. But what's keeping more people from going on?
Part of it is cultural in the sense that in the pediatric oncology population, by some estimates, over 60% of kids with cancer are in a trial at some point during their care trajectory. So on the one hand, those are specialized instances. Most kids with cancer are cared for at certain centers that are centrally located. But I think there's the idea there that for kids, the hope is that the knowledge about how each and every kid is treated can help to inform the treatment of subsequent patients. I think people are just all in on learning everything we can, because there's certainly there's few things more upsetting or that we really want to address more quickly and appropriately than a kid with cancer. So how do you get from 70 or 60% of kids to 7% of adults? So part of it, I think there's a difference in drive on the part of the patients, providers, the health system, everyone. There's many other factors too. I mean, there's the clinical trial infrastructure in the sense of having enough funding and personnel to bring people into trials. But also, when I talked about culture at the beginning, it also deals with this issue of engaging patients and communities. I mean, how can we make sure we're answering questions that are important to people, to patients? Maybe if we are able to engage community members, cancer support groups, people who are living in communities that are near these large cancer centers, into helping us to identify questions that are important to them, that can help to improve recruitment and enrollment. Trust is an issue. I like to think of the issue of trust, meaning, is the health system behaving in a trustworthy manner, rather than saying, why don't minoritized populations trust us? It's more, why aren't we behaving historically and currently in a more trustworthy manner to ensure that we're engaging in meaningful partnerships, to ensure that we are recognizing and addressing the long track record of racial disparities and oppression of surrounding communities. And then also cost just relates to that issue of systemic racism, but it's beyond that. But there's also cost to patients, both time cost, people showing up to a trial or having to bring a family member to a study means they may be missing work, other important obligations. But also sometimes there's out-of-pocket costs, ranging from parking to food to actually the treatments involved. So I do think it's critical to think through both equity, overall access, trust, and our trial infrastructure.
I think sometimes people are afraid of clinical trials. They're afraid of, as I'm often asked by patients, why would I want to be a guinea pig? And I think that one of the challenges for doctors and other research staff is explaining to patients the different types of clinical trials. And then, in fact, the whole concept of being a guinea pig is probably not the right way to think about it. When we're talking about large clinical trials or randomized phase 3 trials, we're usually talking about looking at the standard treatment and trying to compare something that a lot of people think might be better than the standard treatment. Because our goal, of course, is not to worsen outcomes, worsen how people do, but to improve it. And we typically test treatments that look quite promising.
Absolutely. And also just thinking back to that comment by Dean Saul Farber about half of what we tell you is going to be wrong. We just don't know which half. I think also relaying to patients that, at the end of the day, we're not totally sure what works. So we have to test new versus the standard of care, but also test two different standards of care against each other. So that's one thing, is we should always be learning, and because maybe conveying in a way that doesn't scare people, but conveying in a way that we're often operating in a vacuum of information. We're often making decisions without the best available evidence, and we're going to every step we can take toward decreasing that uncertainty is a step that'll help, if not you, it'll help future patients.
No, well, there was a time when I think people believed that the trusted family doctor had the answers to all questions. Medicine is so complicated that no single individual can have all of those answers. For that matter, no single specialized cancer doctor. I'm a breast cancer doctor, but there are certainly many questions in breast cancer that I don't have an answer to. And we need to, many. And, we need to be honest about that, and we need to try to learn, because that's the only way we're going to make a dent in really changing both the suffering and the loss of life that we see from cancer and other diseases, for that matter. Maybe we can talk a little bit more about equity in healthcare, and how the work that you and the people who work with you do can shine a light on the challenges with equity. And how big are those challenges?
They're as big as they get, in the sense of the long-standing structural racism and classism that confronts our society.
And for that matter, I mean, in truth, anything that makes someone a little different, whether it's, and race, of course, is the one that is most obvious, and causes probably the biggest challenge, but sexual and gender identity and education level, and probably even things like obesity, which lead to less than optimal care.
Absolutely. And if you think about it, at the same way we, in the cancer field, are very interested in, appropriately interested in precision medicine. Like if you have a certain marker on your lung cancer cells, you have a certain mutation, and that could put you in a different risk factor. Similarly, if someone is living in an impoverished community that doesn't have enough food to eat, has a very low income, had suffered from these effects of racism or sexism or homophobia, those could be markers that could be used to identify people who need additional resources or attention to ensure they're getting the care that they need. So one study that we've been working on over the past few years with Dr. Emily Wong at the Seish Center here at Yale is looking at incarceration and cancer care. So Emily has this long-standing and really wonderful track record and interest looking at incarceration and health outcomes. And she worked with our group, the Copper Center, which is our Cancer Outcomes Center. And we partnered with the Department of Corrections and also the State Tumor Registry to do a data linkage where, without releasing any identifiers, so we never saw who any patients actually were, but that they created a de-identified database to allow us to explore at the population level the relationship between being incarcerated and cancer detection and cancer outcomes. And what we found was that among people who are incarcerated, if you were diagnosed while your cancer was incarcerated or shortly after release, we found there was a higher risk of later stage cancer and also a higher risk of mortality. It doesn't mean to say that this is because the cancers are being completely ignored in the incarcerated population. However, it does say that there is potential opportunities for improving screening or identifying opportunities for getting people better plugged into care. So this is a partnership that's ongoing. So we're working on submitting grant proposals to perhaps develop new approaches to screening in the incarcerated population. So it's a good example of, through Emily's longstanding relationships, the importance of building partnerships that are, focused on a certain mission, which is in this case improving care access and outcomes. Here focused on cancer, but that's one aspect of equity that we're focusing on. Is this incarceration and cancer link.
One of the parts of this story that I find most incredible is that, if anything, the outcomes for people who are previously incarcerated are, if anything, worse than people who are actually in prison at the time. And, you can imagine that prison provides not a great safety net, but at least there's some safety net and some care, and one leaves prison and there's just nothing. And it's a really remarkable story, and I think one that most people wouldn't think about much. But it adds to the huge burdens, of course, that we place on people who are incarcerated. Maybe we can shift and talk a little bit also about patient-centeredness in cancer care.
Yeah, thanks. That's such a critical question. One area that it's particularly important to think about personalized care is the older patient with cancer. There's this new-ish approach, which is hopefully becoming more commonly used, is the geriatric assessment. So forming a really nice partnership between the geriatrics and the oncology providers to do a thorough assessment of not just, what stage is your tumor, but also what is your functional status? Do you have social supports? Just a few of these questions that are part of this geriatric assessment can identify patients who are at risk of running into problems with side effects and treatment toxicity. So really tailoring treatments based on where patients are holistically.
Dr. Carey Gross is a professor of medicine and of epidemiology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.